Okay, everyone, this is the Chapter 31, Coordinating Care for Patients with Vascular Disorders. Okay, as you see, here are the objectives for this chapter that we are going to be discussing. And just let me point out that anything that is not covered with the lecture or pointed out in the book is not going to be testable material. So when you go through and you're studying all this material, please pay attention to the different things that I point out to you and should be highlighted in your book as far as tables and charts and such. And just remember that the recurring themes, you're going to hear a lot of stop smoking, lower cholesterol, better nutrition, better diet, exercise. You're going to hear that continuously through this PowerPoint. So just remember that all that is related to the heart and circulation issues. Okay, so we're going to hop into atherosclerosis versus arteriosclerosis. Okay, you have to remember it's the thickening or the hardening of the arterial wall due to aging. That is the definition of arteriosclerosis. Okay, so atherosclerosis is atherosclerosis is where the arteries have the buildup of plaques. Okay, so atherosclerosis versus arteriosclerosis, you're talking about whether it's a hardening of the arterial walls or if it's the buildup of plaque. Okay, so with the buildup of plaque, it is where the, with that buildup, it narrows the arteries with the thickening, okay, versus the hardening of the arteries, which is a thickening. And you can have arteriosclerosis without atherosclerosis. Okay, if that makes sense, because you can have hardening of the arteries without the plaques. But usually when you have plaques, you have the hardening and the thickening. So some books actually use these two terms interchangeably, so you have to look at your sources. Our book does not use these interchangeably, so that's why it's like the first paragraph right underneath on page 592 that kind of starts to try to describe the differences. Also, the LDL protein, lipoproteins, build up in the arterial wall, which they kind of attribute those to the plaques, and those plaques with the thickening and the hardening. And we'll be discussing those as we move through. Okay, so this is just the picture that I included in the PowerPoint, so you can see a normal artery, an artery buildup with plaques, and then an artery buildup with fats. And just remember that those plaques, as they build up, they're going to make the arteries less flexible, and that's where they're going to become hardened. So that's what's going to happen actually in the arteries of the body. Okay, so the disorder is caused by atherosclerosis, or CAD, coronary artery disease. Also, CAD can stand for carotid artery disease. So you have to know if it's a coronary or if it's carotid. HTN is hypertension. A AAA is an abdominal aortic aneurysm. And PAD is a peripheral artery disease. So again, always pay attention to your abbreviations and know what your abbreviations can mean. We will refer to CAD as carotid artery disease. So anytime you hear CAD moving forward in this lecture, you will think of the carotids, or you should think of the carotids. Okay? So the risk factors for atherosclerosis. So you have to think about the plaque building up, the fats, and what's going to happen with all what's going to happen. So you're going to have elevated cholesterol levels, elevated triglycerides. You have the elevated LDL and the decreased HDL. Okay, the LDL or the low density and the HDL or the high density. What I learned way back in school was that HDL were the happy lipoproteins, and you wanted more of the happy lipoproteins rather than the LDL, which were the mean lipoproteins, because with the controlled levels and with the levels that you need, if you have a higher HDL, then you should have less carotid and less artery disease. Again, hypertension, we will touch on it further in this lecture with the exact breakdowns, but hypertension is any abnormal high blood pressures. Diabetes, of course, diabetes would be any illness or disease associated with high blood sugar levels. Family history. Again, you should be looking and be asking your clients what their family history is, what's in their family history. Obesity. The book wants to go into and talk about BMI levels with obesity. However, we all know that athletes and people that work out have higher BMIs, so I'm going to not really go into BMI with obesity. A sedentary lifestyle. A sedentary lifestyle is any lifestyle that the person does not get enough exercise. And as we learned in 30-30, people should be doing at least 30 minutes of cardiovascular exercise at least 3 to 5 times a week. Anything less than that would be a sedentary lifestyle. And race. Okay, the races that are usually have more cardiovascular disorders are usually the African American race and the Native American Indian race. There is one exception to that where male Caucasians are at more risk. But again, you have to know which illnesses have the different issues with race. Okay, so assessment. Always start with assessment. You have to figure out what the family history is. Is there a genetic link with atherosclerosis? You're going to look at their blood pressure. You want to always see if hypertension runs in the family. Are they having any pain? You want to look at your old cards for pain. Check pulses. You always want to check every pulse bilaterally except for the carotids. You do not want to check carotid pulses at the same time, and that can cause any kind of pressure on the carotids at the same time. It may cause a decrease in blood flow. You can actually cause the person a stroke or loss of blood flow to their brain, so you do not want to do that. That is the only pulse that is not checked bilaterally. Shortness of breath. What is their breathing status? Are they labored, unlabored? Is there a cough? Is there any kind of production with that cough? Is it a non-productive cough? Is it a productive cough? If the cough is productive, is it having what kind of drainage is the cough bringing up? Is it a light tan? Is it a green? How much? And these are all questions you should be asking. Complaints of fatigue. Is there fatigue? What causes the fatigue? How long is the fatigue? And of course, their lab levels. And the different labs we're interested in is their basic metabolic panel. So the basic metabolic panel, we're talking about sodium, potassium, the electrolytes. For the blood panel, we're looking at hemoglobin, hematocrit, red blood cells, white blood cells. For the triglyceride levels, we're looking at what levels are their triglycerides at. The target HDL level and LDL level. And then the total number of triglycerides. A level of greater than 150 milligrams a deciliter is an unhealthy level of triglycerides. And remember that triglycerides are then split into HDLs and LDLs. So you want, if your HDLs are supposed to be at 50, then your LDLs better be at 100 to get your 150. So that's where that comes into play. Wherever your HDLs are, then your LDLs. Remember I said you always wanted to have more HDLs than LDLs? Well, that would be why. If you have a higher HDL number, then your LDL number should be lower to equal that 150. Okay, and they work in combination. What I wanted to mention when I started this PowerPoint, sorry about that, I forgot to silence my phone. It's silenced now. If you have any questions moving through this lecture, write your questions down. Hopefully the questions will be answered later in the lecture, or if you continue to have the question, then you may email me, okay? But that's what to do if you have any questions. Okay, labs. The other labs we want to look at is the HB, hemoglobin A1C, HbA1c, and if it's greater than 7%, then the person may have an illness with diabetes. So that's where you want to look at, that's where the diabetes comes in. So what are we going to do? What should we do as nurses? Always we're going to analyze that lab data, and then we'll decide what actions we need to take. So if their LDLs are higher than they should be, then maybe we need to do some diet teaching. If their blood pressures are high, then maybe we need to start thinking about what can we do to help them lower their blood pressures. Is it their stress level that's causing the high blood pressure? Is it smoking? Is it smoking? What is causing their stress level? Remember, exercise. What is their exercise level? What do they consider exercise? Okay, it's all of these things. Okay, so then we move into the nursing diagnostic labels. Risk for ineffective tissue perfusion, acute pain, ineffective peripheral tissue perfusion, decreased cardiac output, chronic pain. Okay, so these are some of the diagnostic labels that you may see along the way, and I hope that they would all make sense to you, and if not, to think about what could be causing it. Acute pain. What causes acute pain? Ineffective peripheral tissue perfusion. How are you going to know that? Decreased cardiac output. Remember cardiac output. What is cardiac output? It goes back to 30-30. Chronic pain. Is it an acute pain? Is it a chronic pain? What causes the chronic pain? Again, moving back to old cards. Okay, so the planning. What is the nurse going to do? All right, so we're going to look at the assessments. We're going to look at their labs. The labs that they're showing up in the assessments. What does the person understand what is actually going on? If they need to start having a healthier diet, then how will we help with them? And then with all that beyond that, are they going to accept the changes? Okay? The evaluation process is going to be how well we can manage their diet, exercise, stress management. If they're a smoker, are they willing to stop smoking? How can they stop smoking? Okay? So then, again, the nursing interventions. I think we've already talked about this. Lifestyle changes. Do they smoke? How do they eat? Are they active? What do they consider active? And the evaluation process. Okay, so now we're moving on to hypertension. Okay, hypertension is elevation of blood pressure, and it can affect the target organs. Now, the target organs are the heart, kidneys, brain, and eyes. Okay, so if their blood pressure remains elevated for a certain amount of time, does it affect any of those other issues? So, it is a major risk factor. It's a very common problem. It is manageable. It is modifiable. Okay? High blood pressure can be an initial sign to other issues. And again, the other issues you're gonna find in the systemic areas: kidneys, brain, and eyes. So we're going to move forward to essential hypertension. Okay, essential hypertension is also called primary hypertension. It is the hypertension that presents without any other medical illness. So these are the people that walk in with high blood pressure that do not have any other illnesses. Okay, some of the links have been made to obesity, diet, smoking, and vitamin D deficiency. Okay, you're also going to look at age, gender, race, and socioeconomic status. And you're going to ask why socioeconomic status. You're going to think of insurance. Do they have the insurance? Do they have the means to pay for medications? Things like that. You're looking at people that may be 65 or older that have hypertension. These may be people that have a normal blood pressure when they're 55, and all of a sudden now they have a high blood pressure when they're 65. Again, race, you're looking at African Americans. Let me repeat that essential hypertension does not have any identifiable medical cause. It can be hereditary. So, when you do your health history, you're going to find out, do they smoke? What do they eat? Okay, moving on to secondary hypertension. This is hypertension that can be linked to other medical illnesses. Some of the other causes of secondary hypertension would be kidney related, can be endocrine related, drugs, alcohol. Okay, sorry about that, I got interrupted. Drugs and alcohol. Alcohol intake. How much does someone drink during a regular day? Oral contraceptives also can become an issue. NSAIDs, corticosteroids, cocaine, eating too much licorice, believe it or not. Licorice can contain a toxin in it that can mess with the regular biorhythm of the body with the different hormones. So I want to say especially black licorice. So I believe that's why it's hard to find black licorice in stores these days, and mostly you'll see red licorice. So the red licorice doesn't seem to have any lasting effects like the black licorice does. Okay. All right, so assessment. You're going to walk into a person's room. You're going to find out their family history, their diet history. Do they smoke? What kind of pain do they have? Vision. Remember, uh, high blood pressure can affect the vision. So do they have any visual impairments? When did the visual impairments start? Is it a chronic visual impairment, or are they new visual impairments? You're going to look for the peripheral edema. You're going to look for pulses. Again, except for the carotid artery, you are to check every pulse bilaterally. You're checking them bilaterally to see if they are equal. You're going to look at their lab values. Again, we already discussed what lab values you should be looking at. This little box here on this slide, you can see hypertension. You can see with this little box, you can see that the arm is showing circulation. You can see that the heart is there, the kidneys are there. And when I see that globe, I think of the eyes and the brain, okay? So these are all target things that we should be looking at. Okay, so our nursing diagnostic labels are right here: deficient knowledge, risk for ineffective therapeutic regimen, risk for decreased cardiac output, activity intolerance, fatigue, ineffective coping, and risk for electrolyte imbalances. So, planning. What can we do for these people? If they are on a medication regimen, what do they know about it? Do they know enough? Do they understand what medications they should be taking, how they should be taking them? If they miss a dose, what should they do? Are there any side effects from these medications that may want to stop them from taking these medications? What is their diet? What does their diet consist of? Exercise. So the nursing interventions, okay? Manage blood pressure. So what can we do for them for their managed blood pressure? Okay, the table on 31.3 and page 598 talks about blood pressure's classifications. A normal blood pressure is less than 120 up to 120 and less than 80 up to 80. Then we talk about pre-hypertension. It's just 120 to 139 over 80 over to 89. Stage 1 hypertension is 140 to 159 over 90 to 99. Stage 2 is greater than or equal to 160 over greater than or equal to 100. If someone goes into hypertensive crisis, you're talking about someone that has a sudden rise in blood pressure. So if they have a sudden rise in blood pressure and they've never had anything, so then you want to do your assessment. Are they having any other issues? And that's when you look at their circulation, their vision. Ask them how much they've been passing their water. And what I mean by passing their water, talk about urination. Remember the target organs: eyes, brain, kidneys, and hearts. Okay? And as you look at all the little emojis over here on the side, you can see vision, sleeping, fatigue, pain, temperature, stress, breathing, all of that. Okay? So hopefully, this will help you think about your nursing interventions and what you can do. So the evaluation process. So always with evaluation, you want to look at how are they doing, their medication regimen, their lifestyle management. Is it prevention of hypertension? Is there lifestyle changes that they need to make? Their weight. Are they overweight? What should be considered a normal healthy weight for them? Their diet. Dietary salt intake. Depending on how much salt they're taking in can be how high their blood pressure is. are we going to maybe try to get a DASH involved? DASH is a dietary approach to stop hypertension. It's a diet high in fruits, vegetables, and low in dietary fat. Okay, that's in table 31.6. Table 31.6 at the top of page 600. So it talks about grains, 6 to 8 a day, fruits, 4 to 5 a day, vegetables, 4 to 5 a day, low fat or non-fat, 2 to 3 a day, lean meats, fish, poultry, 6 or fewer a day, nuts, seeds, legumes, 4 to 5 a day, fats and oils, 2 to 3 a day, and sweets, 5 or fewer. And when I talk about those numbers, you can see in that chart that's how many servings. Okay, so when I said about meats of poultry, 6 or fewer a day, it doesn't mean go eat 6 chickens. You don't want to eat 6 whole chickens. It's what portion of a chicken are you going to eat, okay? You talk about exercise. Again, exercise is at least 30 minutes of aerobic exercise on most days of the week. So we're talking 3 to 5 days a week where you have to do 30 minutes of aerobic exercise. Okay? We talk about peripheral artery disease. Okay? It's the majority of people 65 years or older, African Americans, are more affected than any other group. Remember, the PAD is atherosclerosis. One of the key modifiable risk factors are smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, obesity, and ineffective stress management. The non-modifiable risk factors include age, gender, ethnicity, and family history. Okay, you're talking about a progressive and chronic condition where the obstruction of blood flow is through the large peripheral arteries. Then it could be a partial or total occlusion. Okay, it could be a combination of atherosclerosis, inflammation, stenosis, embolus, and thrombus. It deprives the lower extremities of oxygen and nutrients. It's inadequate tissue perfusion. It could be that can lead to ischemia or cell death. So we have to start thinking about what's going to happen with, PAD. Okay, so the first term we're looking at is claudication. Claudication is leg ischemia. Okay, it can have pain, aches, cramps, numbness, or sense of fatigue. Usually happens in the calf. So as you see here on this slide, there has the stages. The stages are in table 31.7 on page 602 in your textbook. Stage 1 is asymptomatic. The presentation, again, is here with no claudication, but you can hear a bruit. A bruit is a harsh blood flow sound, okay? If it sounds, and the harshness comes from the hardening of the artery as it's trying to move through. That's what makes it a harsh sound. Stage 2 is claudication. It's muscle burning and cramping with exercise, and it's relieved at rest. And this can be reproduced when you exercise, and when you stop, it stops. That's stage 2. Stage 3 is rest pain. Okay, this is pain that is not relieved at rest. It may wake you up in the middle of the night with sudden pain. The pain is described as numb and burning, and it occurs in the lower extremities. Pain can be relieved by putting the extremities in a dependent position. Okay, stage 4 is necrosis or gangrene. So this is where the tissue breakdown is occurring. You can have gangrenous toes and even parts of the lower feet can have signs of gangrene. Okay, that is showing that there isn't enough blood flow to give nutrients or oxygen to those tissues. Okay, so we're moving forward with this illness. So this is where the 6 P's come into your assessment. Okay, the 6 P's show up if someone has chronic peripheral artery disease. Okay, the 6 P's: pallor, pain, pulselessness, paresthesia, paralysis, and poikilothermy. Okay, we will discuss the 6 P's further after we look at these diagnostic exams. Okay, these diagnostic exams, I just want you to be familiar with, to know that this is how peripheral artery disease can be diagnosed. Okay, the first is the ankle brachial index, which can be obtained with a blood pressure cuff on the ankle is the same as the blood pressure in the brachial artery. Plethysmography. Sorry, took me 3 times. It's another non-invasive test used to evaluate arterial blood flow in the lower extremities. It monitors the amount of volume flowing through a limb. The treadmill test. The treadmill test is maybe given about the degree of peripheral artery narrowing, and it's how much claudication someone experiences with this exam. Radiography is they can see if there's any narrowing or occlusion of the blood vessels. Okay. Okay, so the 6 P's are very important to know. Poikilothermy is a coolness. Okay, so we're talking about nursing diagnostic labels. So you have to think about what the 6 P's might actually lead to. So we're looking at ineffective peripheral tissue perfusion, risk for impaired skin integrity, chronic pain, fatigue, risk for activity intolerance, and risk for falls. Okay, so the planning. So the planning starts to move into what can we do for these people. So we start looking at, assessment. We have to look at, again, checking their pulses, their temperature, muscle tone. Okay, there may be some medications prescribed, so we'll be doing some medication teaching. What is the client's knowledge level? So our interventions. Okay, so we're looking at what medications are they on? Do they know how to take their medications? We're going to assess the limbs for ischemia. Again, this leads from our assessment. Vasodilation of the limbs. We're going to look at positioning. How should they position their limbs? Should they keep their limbs above the heart, below the heart? What happens with the pain when they put the limbs above the heart, below the heart? Okay? You should have the affected extremities dependent to help with blood flow. So that would mean that the extremities should be lower than the heart to promote that blood flow. Okay? You want to avoid crossing the legs. You do not want to have any obstruction of blood flow to the extremities. Do they have any skin breakdown? So you have to look at their skin. Are they wearing the proper stockings? Again, you don't want anything that's going to restrict blood flow. Do they need the DASH diet? Are they what is their alcohol content? Are they a smoker? Remember, atherosclerosis is the most common risk factor for PAD. So we talk about medical management. The medical management is the percutaneous transluminal angiography. Okay, this is actually a non-surgical, termed a non-surgical intervention, because you have to think about from your day at the surgical suite, from Ms. Stone's lecture, what actually consists of a surgery. Okay, this can be done as an outpatient, so this might not, it doesn't fall into a real invasive, general surgical anesthesia type thing. What happens is a cannula is inserted into or above the artery. They will insert the balloon, and they will open the balloon and then insert a stent. A stent is what it actually is it's a plastic straw reinforced with some wire, and it is sturdy enough to keep the blood vessel from collapsing. As you look at number 4 here, you can really see what it is. And you have to think about how small these stents are. These stents are so small to be placed into the places that they're going into. Okay. Laser-assisted angioplasty. Okay, during this procedure, a laser probe is advanced through the cannula, and it's inserted, and it will have a balloon as well if the balloon is needed, but it will open up or reduce the occlusion with the laser. Arterial vascularization is also where they will go in and they will see what kind of occlusion there is and try to help reduce the occlusion to promote blood flow. So, what are our nursing interventions? Our interventions are to palpate the pulses, inspect the skin, again, feeling for the temperature of the extremity, muscle tone, medication. We've talked about proper positioning, and then as always, we want to use education. So the evaluation. With the evaluation process, you're going to see if there was relief of the symptoms. Did it improve their quality of life? Was the education accepted? Did they understand? What further education do they need? Okay, so coronary artery disease, CAD. Okay, it's atherosclerotic blood vessel disease. Okay, some of the major complication is stroke, and that's due to carotid atherosclerosis with the severity of the stenosis, or whether or not the lesion has previously caused symptoms. Again, risk factors: smoking, hypertension, diabetes, dyslipidemia, sedentary lifestyle, obesity, and effective stress management. Again, sounds the same, right? So all of these risk factors are the same for all of these vascular disorders that have atherosclerotic changes. Okay? So if you know the risk factors for atherosclerosis, you just have to remember to find out, is the illness that you're talking about caused by atherosclerosis? If it's caused by atherosclerosis, then you should be able to apply all the risk factors that are there. Again, the non-modifiable risk factors are age, gender, ethnicity, and family history. Okay? Women over 75 are at a higher risk than men. So, assessment. We're going to look at what we can do. So, you're going to listen to the carotid with your stethoscope to see if there is a bruit. Okay? You're also going to look for signs of a stroke. Signs of a stroke are sudden weakness, maybe one side more than the other, dizziness, loss of consciousness, difficulty talking, facial droops, sudden visual disturbances, sudden headaches. Okay, so the easiest things to assess is while you're assessing your client, you're going to look at them, see if they can track you with their eyes. While they're tracking you with their eyes, what does their face look like? Ask them to smile. Sometimes people smile when you walk in the room as a form of being courteous and, accepting that your presence is there. So when they smile, can you see both sides of their mouth go up at the same? If one side goes up and one side doesn't, you may be looking at an issue. Do they have sudden visual changes? Again, you're looking at your target organs. Your target organs are your kidneys, your eyes, your brain, and your heart. Do they have sudden headaches? Okay, so what we will do is some of the diagnostic exams. We're looking at a CT. We're looking at an MRI, and we're looking at an MRA. The difference between an MRI and an MRA is what it's looking at. You can see an MRI is magnetic resonance imaging. The MRA is magnetic resonance angiography. So what the MRA actually does is it actually focuses more on the vasculature rather than the image itself. MRIs visualize soft tissue. So anytime you go for an MRI, you're actually not looking at a structural issue as a tissue issue. When you look at a structural issue, you will get an X-ray. When you look at a tissue issue, you will get an MRI. Okay, so our nursing diagnostic labels are risk for ineffective tissue perfusion, risk for injury, and anxiety. So planning. Okay, what can we do? Okay. Symptoms lead a lot to how we treat the person. So if the symptoms are not resolved with the medication regimen, maybe the medication regimen needs to be changed. You have to remember our scope of practice. We do not change the medication regimen. We can educate on the medication regimen once it's changed, but we do not change it. Is there a surgery? Is there a surgery that can help prevent for the symptoms, or is surgery even mentioned by the provider? Okay, so then I moved on the slide thinking that we might see some assessments. So we're looking at the assessments. You have to palpate the pulses. You're going to look to see where the pulses are. They equal bilaterally. The visual assessments of the feet and limbs. Is there any signs of tissue injury? What is the temperature of the tissue? Is it cool? Is it warm? What's the muscle flow? What is their muscles? Are their muscles strong, weak? Is it one-sided or are they bilateral? Okay, do they understand what their condition is? If they don't understand their condition, what can we do to help them understand? What further teaching do they need? And do they understand their treatment? Okay, so surgeries. The one surgery is a carotid endarterectomy. Okay, so in a carotid endarterectomy, it's when surgery is used to remove the plaque causing the occlusion in the carotid artery. Okay, the goal of surgery is to improve the blood flow to help prevent further symptoms and prevent stroke. After surgery, the client usually goes to an intensive care setting where you're going to monitor their heart, you're going to monitor their vital signs. You want to keep them under close supervision. Okay, what do we as nurses do? We're going to make sure their vitals are being checked and monitored. We're going to see how their mental status is. How are they doing neurologically? Is there any bleeding or drainage from their incision sites? And we're going to monitor their incision sites for infection. Okay, so during the surgery, a balloon is placed up into the carotid, and they will do the angioplasty. And if there's any stenosis that is still remaining when the balloon is removed, then a stent might be placed. Okay, what to watch for after a carotid endarterectomy, also called a CEA, is in table 3110 on page 610. You're going to look at possible complications, respiratory impairment. What we do as nurses, we're going to monitor the respiratory rate. We're going to look at the trachea for any midline deviation. We're going to listen to their lungs. Hypotension. Again, we're going to make sure that we monitor their blood pressures. Hypertension. Again, with the blood pressures. There may be PRN antihypertensives on call. So you need to know the medication list for this person. If their blood pressure is reaching a certain point, then we do not want it to go over and above. So there may be a antihypertensive that may be given. Neurological dysfunction. So you're going to look at your different cranial nerves. You're going to see if the cranial nerves are affected. Okay, there are medications in the next chart on page 611. You will learn your medications in pharmacology. For the incision sites. The incision site, of course, is going to be in the neck area. So with it being in the neck area, you have to think about what's going to cause stress and pressure on those incision lines. So naturally, you want them to keep their head straight. You do not want them to turn their head. You don't want them to extend their neck to, again, put any pressure on those incision lines. You want to make sure that there isn't any additional bleeding. Okay, you want to make sure that and this goes along with the neuro assessment, that the person is their level of consciousness is the same. They have a change in their level of consciousness after the procedure. You need to know what their baseline was prior to the surgery. So these are all things that you need to know. Okay, These are things that you will get in report and you need to ask questions about. Okay, so the carotid artery stenting, I kind of already alluded to this. This is where the guide wire goes up in, the balloon is there, and if the stent needs to be placed, they will place the stent. Okay, also we're looking for blood clots. Okay, we do not want any blood clots to occur during this procedure. So they may be on some anticoagulants, or there may be some anticoagulant therapy after the procedure. Again, if someone has a surgical incision and you have them on anticoagulants, you need to watch the incision sites for bleeding. Okay, you do not want any drainage at these sites, depending on the anticoagulants as well. So, again, we talked about the assessments. Assessments are so important when you talk about someone with a CEA. So, you're going to monitor their mental status. You're going to check their vital signs, their laboratory values. So when you're talking about anticoagulants and their lab values, you're also going to look for bleeding. So you're going to watch their hemoglobin, their hematocrit, and then their red blood cells. If you're looking for infection, then you're going to look at their white blood cells. For signs and symptoms of bleeding, you may want to look at their platelet levels. Okay? I'm not going into any of the actual lab values, because if you're at the hospital and you're opening up their chart, we all know that the hospital says what values are high, low, or normal. So you will have the H for high or L for low, and that's what's going to call your attention. If they're critically low, we know that there's going to be an alert sent to you that someone has a critically low value. Nursing diagnostic labels for this are risk for ineffective tissue perfusion, risk for injury, and anxiety. So planning. So just from this picture on this slide, you can imagine what all you need to think about when you're starting to talk about planning. Just from this picture, you can see their incision site. You can see in this picture that they actually use the steri strips to close this. So right away, when you're looking at laboratory results, what is their coagulation? What is their hemoglobin? What is their hematocrit? What is their blood pressure? Is their blood pressure too high? Could their blood pressure make any of these incision sites start to bleed? In this picture, you're also looking for redness around. Is the wound clean, dry, and approximating? When we talk about approximating, are the tissue edges starting to mend? Are the tissue edges showing any signs of opening? Okay? You have to look at that. What is the client's status? Are they alert? Are they oriented? How are they speaking? How do they look? Are they complaining of any pain? Talk to your patient. So the interventions, again, vital signs, very important. We're going to manage their blood pressure. You should know with PRN medications what their medications are, their laboratory values. If they're diabetic, we better be paying attention to their blood sugar levels. We already spoke about their incisional sites. Neurologic checks. What is their mental status? Their prescribed medications. Does the client understand what lifestyle changes they may need to have? Were they smoker previous? What kind of smoking cessation do they have? Are they diabetic? What kind of diet are they on? What kind of exercise program do they do at home? What is their general lifestyle? Okay, when we're looking at evaluation, we're looking how are they doing after surgery. their follow-up appointments. Do they understand if there's a lab value issue, what can we do to make sure that while they're at home, what they can do to change those lab values? Does the client understand what their current status is and what status they should be looking forward to? What is the person doing for themselves when they leave the hospital? Do they have a social support system? Do they have someone that can look at their incision sites? Do they have a mirror at home? It should have a handheld mirror, not to be touching their incision sites, but just looking at their incision sites. If there is dressings that still need to be applied, do they have visiting nurses? Who's going to care for these people? Okay. Aortic artery disease. So aortic artery disease, it's an aneurysm in an aortic artery. Okay, more commonly known as an abdominal aortic aneurysm, AAA. Okay, men are five times more likely than women to have a AAA. Caucasians are higher risk. A AAA can be true or false. Now, the status of true or false depends on the layers of the arterial walls that are involved. Okay, if all three layers of the arterial wall are involved, then it is a true aneurysm. If only the outside layer of the arterial artery are involved, it is a false aneurysm. Okay? A false or pseudoaneurysm is not a distortion of the vessel, but rather a leak from the arteries. The surrounding tissues eventually form a blood clot, and this can puncture, and actually it's usually a complication from a surgery. Okay. The risk factors involved, again, family history, age, gender, race, smoking, atherosclerosis, hypertension, and cholesterol levels. A few pages back, as I meant to mention it to you, as lab results, is LDLs should be below 100. So that's one of the lab values that we are looking for. So when we're looking at the total triglyceride level, if you have an LDL of 100, then your HDL could be 50 for your total of 150. But if you're having 100 as your LDL total, that's too high. So that is too high a number. So remember, you want that number lower than that. Okay? That also goes for this cholesterol level as well. You do not want the LDLs to be so high. Okay, so what kind of assessment do we see? All right. Usually someone doesn't know when they have a AAA. Okay, you may find a pulsatile, palpable mass in the abdomen. Okay. You might have chest, back, or flank pain, and the pain can be spontaneous. Now, if the mass is palpable, you'll probably hear a bruit. So you will listen, and if you find a palpable mass in the abdomen, you want to use light touch. You do not want to press hard on that. You do not want to cause that to rupture. Okay? Someone that has immediate pain, that can be a bad sign. Okay? So we do not want an immediate pain. The size and location of the aneurysm also start to become important. So the size will be seen on a CT scan and abdominal ultrasound, and less than 5 centimeters in diameter, you do not usually have any kind of surgery. Surgical intervention is to monitor the growth of the aneurysm over time and to maintain blood pressure at a normal level to help decrease the rupture. Okay. CT scan is the gold standard for assessment of the size and location of a AAA. Medications are going to mostly be used to help decrease hypertension. Okay, that's what we want to do. We want to decrease the blood pressure. We do not want an increase in blood pressure that may cause an increase in size or anything to cause this AAA to rupture. Okay, so medical management is, size and location determine the treatment. I'm looking at the picture on this slide, and there are two different types of aneurysms. There is the saccular and there is the fusiform. So that's what these two little circular globes are showing you, that if it's a saccular, you have to think about that is all three parts of the artery being involved there that to form an outpouching of a saccular aneurysm. Or if you have the fusiform, you can see it's more of a rounded, all-around circumference of the artery. And then you can see where the pseudoaneurysm, you can see where I said it only involves the outside layer of the artery. Okay, anytime you do surgical management, you always want to weigh the outcome versus the prevention. Okay, endovascular aneurysm repair, it's EVAR. The risks include bleeding, infection, infarction, and graft occlusion. Anything larger than 2 inches or 5 centimeters, they're advised to have some sort of surgical intervention. Any aneurysm that gives symptoms, they advise to have surgical intervention. Any growth of 0.5 centimeters in 6 months, they may advise to have surgical intervention. So the EVAR is an alternative to open surgical repair, and it has reduced risks. The EVAR has shown with research to have less chance of bleeding, MI, renal failure, or graft occlusion. So the EVAR is the recommended surgery if someone needs to have an intervention performed. So the complications, aortic dissection. Those are dreaded words to hear, because if you have an aortic dissection, that means the aneurysm has burst. You will have sudden, severe, and persistent pain. They will have a sensation across their anterior chest to the shoulders, and they will feel it in the epigastric area and abdomen. They can have diaphoresis, nausea, vomiting, and they can faint. Their blood pressure will obviously change, and they can go into hypovolemic shock from a massive blood loss. Okay, just remember that if someone doesn't have surgery and they're walking around with their AAA, if they have a rupture, they can have life-threatening complications. You're talking about someone that might present with differing blood pressures in their extremities, pain, loss of consciousness, and if it's not corrected quick enough, this is someone that could possibly pass away. So the nursing diagnostic labels for this are risk for ineffective peripheral tissue perfusion, acute pain, fear, decreased cardiac output, risk for falls, ineffective coping. So the plan would be to educate them on their condition. What are they going to do? How are they taking care of themselves? Are they having pain? What should they do? Okay, I put this little graphic on this slide to kind of help remind you of what's going on, where it can be, what can happen. Okay, you have the artery on the left with the kidneys hanging out there, trying to kind of talk about what the size is and everything. He's telling you to call the surgeon. On the right side, you have this elderly gentleman talking about his hypertension and different things like that. So, this is there to remind you of what can actually happen. So our interventions, we're going to start off with the neurologic assessments. And what is their level of consciousness? Their vital signs. What is their blood pressure? What was their highest blood pressure? What was their lowest blood pressure? How is the person feeling? Their pain. Are they having any pain? What is their cardiac status? What are their peripheral pulses? What do their extremities look like? Are they normal color? Are they pale? Are they warm? Are they cool to touch? And what is their peripheral sensation? Use light palpation for their abdomen. Listen to their abdomen. Do you hear a bruit? Do you not hear a bruit? Do you hear the regular bowel sounds? Remember to administer their prescribed medications. The prescribed medications should probably include a stool softener. The stool softener will help with a decreasing blood pressure during defecation. You want them to keep their legs flat in bed. You do not want them to cross their legs. You do not want any occlusions in their peripheral blood pressure. You probably are going to keep this person on bed rest. So you want to make sure that if they're on bed rest, are they allowed to get up and use the restroom? Is it bed rest with VRP or bathroom privileges? Is it total bed rest? Or, what is their activity limitations? What are you going to teach them? Do you need to teach them about their medications? Do you need to teach them about what the complications are? What is their knowledge level? What is their education level? What kind of things do they need to learn? The evaluation of this is, do they know their prescribed therapy? Do they know what their blood pressure should be? Do they know what their skin color? Are they having pain? Are they having shortness of breath? What is going on with during them? What is their mental status? Has their mental status changed since they've been in the hospital? Is it better? Is it worse? Do they have the support system if it's worse? Who is going to help take care of them? Who is going to help monitor them? Do they have the visiting nurses coming in? What is all going on with these people? These are all things that you need to think about for discharge. Okay, deep vein thrombosis. DVT is as it's called. It is a blood clot in a large vein. It's usually in the leg and pelvis. If the clot becomes mobile and starts circulating, then it can move through the heart and then into the lungs. And if it moves into the lungs, it can start blocking the oxygen supply. And if it happens, this is called a pulmonary embolus or PE. Okay? People that suffer from DVT and PE, they are said to have venous thromboembolism or VTE. Okay, the risk factors include cancer, varicose veins, prior DVTs, contraceptives, hormone therapies, immobility, and surgical procedures. People that have a surgical procedure that go home are at risk for a DVT because usually the DVT has not had a chance to been diagnosed, and as we all know, people are not staying in hospitals long, so then these people are at a greater risk because then they go home and form the blood clot after they've been discharged. So what are we going to see as far as assessment? Assessment-wise, we're going to look for pain in one extremity rather than the other. We're going to look for swelling in one extremity and not the other. Tenderness, discoloration, redness, and warmth only in one extremity and not the other. So what are we going to look at? Testing-wise, the first laboratory value we're going to look at is the D-dimer. The D-dimer is the test that we find has the most specificity related to blood clotting issues. The D-dimer, if it's elevated, shows that there is a blood clotting issue. After they have the D-dimer, if it's elevated, a couple other tests may come in. They can go for Doppler flow imaging studies. With the Doppler flow imaging studies, what that actually does is it gives a clear view of the vasculature. And if there's a blood clot in the vasculature, it shows up on the Doppler studies. The other is the CT scan. A CT scan, the first thing they look for is the CT of the lungs. If there's any blood clot in the lungs, then they may also think that there is still a blood clot in the legs. So they will have both those studies. An MRI, again, would be the soft tissue study. And with that soft tissue study, it can see if there's any blood clots in the soft tissue. So, nursing diagnostic labels, we're looking at ineffective peripheral tissue perfusion. We're looking at acute pain. We're looking for risk for impaired physical mobility and risk for falls. So, the planning. Depending on where the blood clot is, has a lot to do about what we're going to do and how we're going to treat them. The medication regimen can consist of anticoagulants with heparin, low molecular weight heparin, oral, warfarin, or Coumadin. And depending on how quickly the clot has been found, you may use thrombolytics. Thrombolytics can be used if the clot is very young, and you can use a thrombolytic to break the clot up. Sometimes the thrombolytic is called a clot buster, if you've ever heard that word be used. The thrombolytic will attack the clot and decrease the size of the clot and eliminate the clot. Anticoagulants are not used as a clot buster. Anticoagulants will keep the clot from increasing in size. They do not decrease the size of the clot. I say again, anticoagulants do not decrease the size of the clot. I'm sorry I had to step away. Let me gather my thought. I'm sorry. Oh yeah, I was talking about anticoagulants. Anticoagulants do not stop a blood clot from getting bigger. I'm sorry. Anticoagulants do not break up a clot. Anticoagulants are meant to keep the clot from getting bigger. Get my train of thought back. I'm sorry. Okay, so the planning is what can we do for them? How to prevent further episodes? Are we dealing with someone that has blood clotting issues? Are we dealing with someone that doesn't respond to anticoagulants? That can happen. That is a hereditary factor that can come into that person, and we may need to look at other types of prevention for them. So medical management, we're looking at compression stockings, venous foot pumps, and compression devices. If someone is positive for a deep vein thrombosis, you do not want anyone to be massaging their calves or anything to be squeezing their calves. So these sequential compression devices, or SCDs, are not to be used with someone with an active DVT. They can wear compression stockings and TED hose, but they cannot use SCDs. Okay, the medications. I say you're going to learn your medications in pharmacology, but there are 3 medications that I want you to know from table 3117 on page 621 of your textbook. Unfractioned heparin, low molecular weight heparin, and warfarin. Okay, unfractioned heparin is heparin. Low molecular weight heparin is enoxaparin or Lovenox, and warfarin is Coumadin. So knowing those medications and the names isn't just enough. You have to know what lab values are associated with those medications. So if someone is on unfractioned heparin, you will be looking at their APTT or their PTT. If someone is on Lovenox or low molecular weight heparin, you may look at their anticoagulant values such as PTT, PTINR, but it isn't as important if they are on the low molecular weight heparin or Lovenox. Warfarin or Coumadin, you need to keep a careful eye on their prothrombin time, PT, or their INR. Okay? Underneath those nursing implications, you need to pay attention to those bullet points. Okay? It does say in the book that with the unfractioned heparin that to keep an eye on PTINR. Okay, that is just a baseline PTINR. To manage unfractioned heparin, it is the APTT or PTT that you will use as the determining factor of whether or not the medication is being therapeutic. Because a PT-INR is used for the warfarin or Coumadin. Warfarin or Coumadin can take 3 to 4 days to achieve therapeutic levels. The medication is usually taken for 3 to 6 months after discovery of a DVT. Vitamin K is the only known antidote for warfarin. Diet and lifestyle changes are needed for warfarin. Okay, so surgical management for a DVT can include thrombectomy. Okay, this is real rare when they do that. What happens when they go for a thrombectomy is they will actually go into where the clot is and they will remove the clot. Okay, these are clots that don't respond to medications. So this could be someone that is not responding to the medication, and the clot can be in a critical area that they need to remove it so that you can have blood flow reestablished. Okay, you can do this procedure with the balloon, place a stent. However, the complication is a PE, because if you don't get the clot, or you only get part of the clot, the rest of the clot can move through the circulation, through the heart, and into the lung. And if that happens, then you're going to have shortness of breath, you're going to have decreased oxygen saturations, you're going to have chest pain, and you can even have hemoptysis. So we're not looking at a favorable outcome if that occurs. Okay, so our nursing interventions. As always, we're going to check our vitals, and we're going to add our oxygen saturations into that. We're going to look at the affected areas. Remember, people that are on anticoagulants have an increased chance for bruising. So naturally, you falls or bumping into things, then they may have increased areas of bruising. To monitor the lab values. So remember, what laboratory values have we talked about? We've talked about platelets, we've talked about PTTs, we've talked about PT-INR. Okay? These are what you need to look at when you're looking at anticoagulants. Positioning of the client. Okay? Where, if they've had surgery, what is happening? For positioning, naturally, you do not want any leg crossing. Compression stockings need to be on, but not any sequential compression devices. You want to administer the prescribed medications. You want them to have an adequate fluid amount. You do not want their basic fluid volume to be dropping. You want them to have adequate fluids to help promote a fluid volume. You need to know the side effects of the medications. Again, are they at increased risk for bleeding? And what areas are you going to look at with the bleeding? First areas to look at are the gums and in the mouth. Foods that someone's eating can cause their gums to start bleeding. So if someone is having bleeding gums, then you need to look at their labs. You need to get some labs. You need to make sure that their medication is in a therapeutic range. People that go on long trips, you shouldn't sit in the same position for more than 2 hours. So someone that goes on a car trip, that's why we tell people they should stop every 2 hours, get up, walk around, promote blood flow. People that are on long plane trips, if they can, to get up and walk around. I know you're not always able to move around in a plane like that, but you shouldn't be crossing your legs. Okay? That's one thing we don't want to do is cross the legs. You want them to make all their follow-up appointments, especially if they have just had their labs drawn. Those follow-up appointments also are very helpful in monitoring whether or not the medication is at a therapeutic range. Okay, so the evaluation. The evaluation goes with the medications. Are they taking their medications properly? Are they taking the proper doses? What does their skin look like? Do they have any bleeding? What are their follow-up appointments? Do they understand their conditions? Do they understand what's going on? If they've had a DVT, what does the affected limb look like? Is it returned to the same size and shape? Is the color the same? Is there any swelling? Is there any pain? And then if everything is back to normal for the client, what kind of prevention are they doing to make sure that there isn't any issues on follow-up or anything like that? Okay, so this is the part of the lecture that we talk about with questions. I'm going to take a minute, glance back through my notes to make sure I mentioned everything to you. So I'm going to put this on pause for a second. I just want to go back through the book with you and point out which boxes and charts may be of importance for you. So to kind of help remind you of the risk factors, box 31.1 on page 596 is the major risk factors for the development of hypertension. That's a remind you box. Of course, table 31.3 on 598, we talked about the blood pressure classifications. And then table 31.4 is the hypertension laboratory diagnostic testing. This one talks about the target organs and what you might see with expected findings of those target organs. So if they have a renal issue with hypertension, you're going to see proteinuria, elevated BUN, and creatinine. Endocrine is increased sodium, increased potassium, increased thyroid stimulating hormone. Metabolic, fasting glucose greater than 100 milligrams a deciliter, diabetes. Increased LDL, triglycerides, and a decreased HDL, which we talked about those numbers. And the other could be just the decreased hematocrit. Table 31.6 talks about the DASH diet, which we went through. Table 31.7 on page 602 talks about the stages of peripheral artery disease. You kind of need to know that. Table 31.17 on page 621 we just went through. We talked about unfractioned heparin, low molecular weight heparin, and warfarin. So you should know that. Okay, if you have any additional questions, you can email me or wait. You can email me or wait till you see me. Please, everyone, let's be safe and let's all return back and see each other again. Okay? Thank you for your time and letting me do this for you. Thank you so much.